All right, so today we're discussing syncope and pulmonary embolism. And so as some of you may know, there was a few trials that have come out in the last year looking at sort of the prevalence of PE in patients who are presenting with syncope. So we thought this would be sort of an interesting article to take a look at together, because there has been sort of some conflicting data as far as the actual prevalence, and then we can open it up into a broader discussion about what we do in our clinical practice as far as working up syncope, as it's a fairly common general medicine diagnosis. So the first article we'll be looking at was released in the New England Journal in 2016, which I think most of us are somewhat familiar. It was called The Prevalence of Pulmonary Embolism in Patients Hospitalized for Syncope. The actual name for it, the cute name for it, was the peasant trial, which I'll show you in a little bit where that came from. So the clinical question was, in patients admitted with the first episode of syncope, what is the prevalence of PE? And for the reason why they're asking this was because while we think about PE on the differential for syncope, it's considered to be sort of a more rare etiology, and so it's sort of something that we sort of have on our list of things that can cause syncope. But as far as sort of the classical things that we think about, as far as cardiogenic, neurogenic, etc., maybe a little bit less commonly thought of. As far as the actual prevalence of PE in syncope, there really hasn't been any good data to show exactly what the prevalence is. It's sort of something, again, that's on the differential, but no one really has quite an idea of what the numbers are. So that's what this trial was trying to answer. And actually, current cardiology guidelines don't really even specifically address working up PE in the setting of syncope. So they sort of say consider it, but it's not even like really formally addressed. So this article was done in 2016. Again, the cute name for it was the peasant trial, pulmonary embolism syncope. It was done in Italy, so Italian trial. The enrollment period was from March 2012 through 2014 or so. And so this was an uncontrolled cross-sectional study. And so they basically enrolled patients from 11 Italian hospitals, 2 academic and 9 non-academic hospitals in, I guess, throughout the Italian country. And basically they had pretty wide inclusion criteria. And so they had to just be presenting with the first episode of syncope, and they had to be admitted into the inpatient setting, which is important as far as the inclusion criteria goes. The exclusion criteria was that if they had multiple episodes of syncope, if they had previous episodes, then they were excluded. If they were on anticoagulation already, they were excluded. And if they were pregnant, they were excluded from the trial. Yeah, okay, yeah, we can pause. So any thoughts as far as inclusion, exclusion criteria? As far as like being too broad, too generalized, or maybe too inclusive?
So it was only admitted patients?
It was only admitted patients, yeah.
This might be slightly high risk, because I guess there's some patients who are discharged from the hospital.
Right, yeah. Yeah, so that's one of the criticisms of this article was that, again, this was looking at patients who were admitted inpatient, and so, in the ED or outpatient setting, a lot of these patients, are guys with syncope, and it's pretty obvious that it's like vasovagal or whatever, and they're discharged. So again, as Teddy was saying, the risk, there may be a little bit of selection bias as far as the patients that are in this trial. Any thoughts on the methods? Okay, so we'll move on.
Do they generally have, I don't know if they said this, like, in Italy, I've seen, like, many people seeing we would admit. I don't know.
Yeah, they didn't really specify, but I would assume that, in a first world country, that it's kind of the same sort of principles as far as inpatient management, but yeah, they didn't really specify it.
Because a lot of them are non-academic hospitals, so I also wonder if they're really not that sick.
Right, their threshold may be a little bit lower or higher, and it's kind of hard to say because you don't practice in Italy. I mean, we could say if it was a U.S. trial, we could maybe have a better idea of what non-academic center means, but for us, unless anybody here has practiced in Italy, that may be a little bit hard to gauge. Okay, so as far as the methods, so they did kind of have a standardized protocol as far as what they did for these patients. They asked standard history questions about, kind of typical things we'd ask for a patient presenting with syncope as far as like cardiac or neurologic symptoms. All patients had an EKG, chest X-ray, ABG, and D-dimer. And their DVT risk was assessed using a simplified Wells scores. I don't have the Wells criteria listed here, but basically they, instead of the low, intermediate, high risk profile, they basically split people into low or high risk profiles. And so patients who were at high risk or who had a positive D-dimer underwent a CTA or VQ scan for definitive PE diagnosis. Any thoughts on the methods as far as what they did? Okay, so we'll move on to the results. So based on their power analysis, they enrolled about 560 patients on it. Through the risk stratification, they categorized 330 of those patients as having a low probability of PE, and so they were ruled out with a D dimer. And then 230 of those patients were considered high probability based on risk factors, or they had a high D dimer if they were a low risk patient. And then those patients went on to mostly have a CT angiogram performed. A select handful had a VQ study, and one patient unfortunately died and underwent an autopsy. So as far as the actual prevalence, PE was ruled out in about 83% of patients based on either the D dimer or definitive imaging studies, and about 17% of patients had PE diagnosed. And so their final prevalence was that 1 in 6 patients who presented with syncope had PE. Going into the table 2 for a little bit, it's a big table, but basically pointing your attention to the potential explanations for syncope. So interestingly, when you look at this, so again, these patients still underwent sort of the typical workup for syncope based on the provider preference. And so as far as the actual diagnoses that was concluded, interestingly, about 37% of patients actually did not have a cause for the syncope diagnosed. And you can sort of see that about a quarter of them were thought to be neurologic, neuromediated, and then 20% were orthostatic, and then about 17% were related to cardiac disorders, like such as arrhythmias, etc. Any thoughts on the table of patient characteristics?
I think our patients are larger. 6% that are obese, since that's a risk factor for blood clots.
Okay.
And in the US, like 30%.
Yeah, that's.
Even more than that is something.
Yeah, that's interesting. Yeah, 6% of Italians. I guess you're not a very obese country, which is, I guess, good for them.
And I also think for the undetermined, they let the providers kind of work it up themselves, right?
Right.
It wasn't like you had to check orthostatics.
I believe orthostatics was part of the. I don't think I put it.
Did everyone get it, or?
I want to say everybody got orthostatics, but you have to double check the methods. I think that was part of it. As far as like vital signs orthostatics, that was performed.
So I also think like the undetermined just depends on the evaluation itself.
Right. Yeah. And so a lot of it is provider dependent, and so again, provider practices vary as far as the work of syncope. So, but you would assume that it is kind of a fairly basic diagnosis. So hopefully people would be able to take a reasonable history and sort of determine if they thought it was neurogenic, vasovagal, etc. Blah blah blah.
Go back one slide. It seems like a lot of patients are diagnosed with diffuse skin, like more than my experience here. That's like 20-25%.
Yeah, that was basic. I mean, they basically did it if they had a contraindication to a CTA, so CKD or whatever.
I wonder if that's similar to our proportion. If they have different thresholds, the diffuse skin is probably less specific. And all but like the high probability category, so they might have some more false positives.
Yeah, that's a good point.
What does everyone think about the numbers of the study? I think a lot of people were excluded.
There was, if you look at, there was a little diagram, I think I have it here. So they had about 2,600 patients in the time period presented with syncope, and so almost 1,900 of them were discharged from the emergency room. And so again, Teddy mentioned earlier that these patients who were enrolled in this actual study may have been a little bit sicker for whatever reason, and as Mona's study will go into, a lot of these patients who come to the emergency room for diagnosis of syncope, get discharged pretty rapidly. Mike, I don't know from your experience. I mean, do you guys tend to see a lot of patients in the RE2 with syncope that you guys discharge after like a day or so? Yeah. Right. So as Mona said, yes, there was a fair number who were potential enrollees, but were actually not because they were discharged from the ED. So yeah.
Presumably the discharge patients weren't diagnosed with PE.
Yeah, I guess
Although I guess
26
they could have been.
into 19.
Or even like start out no evidence symptom.
Yeah, I mean, it's probably about 70% of patients who 1900 to 2500 is 2600 is about 75%. So yeah, about through 75% of the patients were discharged straight from the ED. So that's an interesting point.
And it looks like in terms of the clinical features, it's a significant things for respiratory rate, heart failure, and silent DVT. So I feel like we would have already maybe gotten a CTA. I don't know what everyone else thinks. Like if someone had a high respiratory rate,
I guess
Or
it's
clinical science.
right. Yeah. I mean, I don't know. It's I don't know. I think in clinical practice it is kind of variable, and so some again it's sort of whether you think about it or not. And so I think maybe if you're less experienced or maybe like a resident or something, you may not really think of PE on the differential. You may not really think about doing a D dimer or whatever, which is I think was sort of the point of this article is that the prevalence is higher than we may think it is. Or we're just thinking about plain old syncope workup. Okay. Let's see. So we sort of talked about the schematic as far as enrollment for the study already. Again, patients actually, so notably patients who were excluded based on D-dimer did not have any definitive study, but sort of based on what we already know about Wells criteria and so forth, the D-dimer is a good screening study for ruling out PE. So looking again at the results, something we already talked about. So they found that PE was in about 25% of patients who presented with syncope of unknown origin. And then interestingly, PE was diagnosed kind of incidentally, I guess you would say, in about 13% of patients who already had another explanation for the syncope, meaning that they were either diagnosed with like a vasovagal etiology or they thought it was like cardiogenic, etc. So that was kind of an interesting finding in this article. Mona mentioned a little bit about sort of vital sign abnormalities that were detected on initial evaluation, but interestingly, 25% of patients who were eventually diagnosed with PE did not actually have any clinical signs of PE or DVT, meaning that they had no abnormal vital signs or clinical symptoms of DVT. So these were kind of, you can either call them incidental or or not detected abnormalities. Right. Any thoughts on this?
Have you read the CTAs? So there was a study that looked at getting CTAs that were read as positive for PE, reread by chest radiologists rather than general radiologists. And in that study, 26% of them were reclassified as being negative for PE. So this is for false positive.
No, I don't think there's articles in front of you if you guys want to look, but I don't think they specifically mentioned who read them. I think it was just kind of the general radiologist. But going into that segues into our next point nicely. So looking at the thrombotic burden, so when they looked at the PEs that were diagnosed, about half, well, let's say about 40% of the patients had pretty large PE, which would obviously be a reason to have syncope if you have a main PA PE. But interestingly, there was about half of the DVTs, or the PEs were just lobar or segmental ones, which you can kind of argue may or may not be enough to be may or may not be enough to cause an episode of syncope. Then you have the small population of subsegmental PEs, which, as Mike mentioned, maybe if they were looked at more carefully, may not even be true PEs or not. Kind of similar findings on the VQ scan. So again, there was a large defect found in only about 17% of cases. A third of them had a sizable defect, and then almost half of them, didn't have too big of a defect whatsoever. So again, sort of thinking about the thrombotic burden and whether or not its ability to cause an episode of syncope is kind of interesting to look at. Any thoughts on the thrombotic burden? Okay. Some of the conclusions that this article drew was that the prevalence of PE was thought to be, fairly high. And so again, it was about 17%, which is about 1 in 6 patients presenting with PE. Again, this is in the setting of patients who were admitted to inpatient setting and not all comers. And so, you could do sort of the math and sort of determine what would that be if assuming all those patients who were discharged did not have PE. But they did find that the prevalence was about equal among the different centers, and so each center was about 17%. So I think that shows some good internal validity. And the patients, were worked up through the Wells criteria, which again has already been studied many times and has been validated. So some limitations that the article pointed out, and that I also wanted to bring up. Again, as we talked about already, ambulatory discharge patients were not excluded. Patients who were in the low pretest probability did not have definitive imaging. So those patients who were rolled with a D-dimer presumably would not have a PE. But again, there wasn't a gold standard study where every patient had the CT done. And then as Mona and some others mentioned, while they did have some standardized things that they did for the workup of syncope, a lot of it was kind of left up to the discretion of the provider. Any other limitations that you guys, would say about this article? Mm-hmm. Right. Right. So that's a great question. We'll put that thought on hold because Mona has a different article to present kind of the counter argument for this.
And I think the other thing is that maybe they had a PE, but it wasn't clinically significant, or we might not even, it would have never come up, but it might not have caused the syncope in the first place.
Yeah. I mean, there was some mention in the article that even though obviously the main PA ones would be enough to cause syncope, but even things like the smaller ones, if there was like a clot that broke off, can be arrhythmogenic, and so that may be the etiology for the syncope. So it's kind of hard to say whether these smaller ones, were contributing to the cause of syncope or not.
But it's also, if they syncopize for the PE, you're already thinking that that's sending them for like emerging thrombolysis. An important thing to consider, right? If this is the only data you had to look at, if you told me that a syncopation in the prevalent of having like 15 to 20% of them in PE, that's why they syncopize. Like, let's get everybody syncopize on the way up to the floor.
Or at least get a D-dimer, maybe. Yeah.
It's different than other series that I've looked at. It's a lot higher from what I understand.
Yeah. Well.
Yeah, we'll go into
So Mona so that's a great segue into Mona's presentation. So Mona will talk about the second article that we are going to discuss.
So I think after that article came out, a lot of people were like, oh, let's scan everyone, or let's get D-dimers on everyone. So this is an article that came out, I think last year, looking at the prevalence of PE in patients with syncope. So this was a retrospective observational study, and basically they took 5 databases from Canada, the US, Denmark, and Italy over 16 years. They basically looked at people over 18 who presented to the emergency room with syncope, and their primary outcome that they looked for was a discharge diagnosis of PE. And then they also looked for the presence of PE or VTE in general within 90 days of follow-up. What do you guys think about their outcomes that they used in terms of the follow-up?
I guess when you're thinking about coding issues, sometimes they may have a secondary diagnosis if there was a hospitalization, but presumably it's captured with patients.
I think it's great that they did the 90-day follow-up. The one thing that could cause you to have lower findings here is that because they didn't it wasn't a study where they instructed people to use the well score, it's just sort of regular clinical practice. You could argue that they are not doing as good of a job in this study, or that we don't do as good a job generally keeping these up as in the first study where they were encouraging people to use an algorithm specifically looking for.
But I do think, like, if they were looking within 90 days, I mean, that is a long time to clinically present with something. So I think that was a strong point of the study. Although we learned from the other study, 25% of people didn't have any signs or symptoms. Okay. So looking at the results, they looked at a million patients who came in with syncope to the emergency room. And they found in general 0.06% to 0.55% prevalence of PE. When they looked at hospitalized patients in particular, so the group we were looking at in the other study, it went up to 0.15% to 2.1%. I'm not exactly sure where the ranges came from. I don't know. But so definitely higher in the hospitalized patients. And then within 90 days of follow-up, we see higher numbers than originally in the ED. And then VTE in general goes up to 1.37%. So what do you guys think of this compared to what we talked about with the other study? So I mean, a lot lower numbers, but again, they weren't, necessarily following an algorithm doing D-dimers for everyone who came in with syncope, so we might have missed it. But we think, I mean, at least I think within the 90 days of follow-up, something would have presented if it was clinically significant, in my opinion. No, I don't think so. I don't believe they looked. I think they just looked at this. So definitely lower. I mean, I think the fact that they looked at 1.6 million patients with syncope is significant.
Yeah, I mean, the Italian study was like, what, 600 patients? So this is a much larger.
This just goes through the prevalence in general. I can probably skip that. So based on this, it was confirming what others thought before, that it is an uncommon cause of syncope. But I think we have to consider, like, was it just not tested or in the differential? We have no idea. The other thing I wanted to bring up was the fact that, the structured algorithm obviously caught a lot more people with syncope, but are we then overdiagnosing and overtreating people? I don't know what you guys think.
Does it break down the types of found in the study, like by? It's gonna be interesting if it was the lower incidence, but they were catching bigger PEs that were likely more symptomatic, then maybe we were just catching a lot of subsegmental and small PEs in the other study. And then the question is, what is the clinical outcome for people with undiagnosed small subsegmental PEs, and how concerned are we about this?
Yeah, I don't think I mentioned that. Despite how large the study was, they really only looked at a few factors.
Yeah, and it's a chart review, so it's kind of hard to predict.
Yeah.
It's really surprising to be able to 6%.
Yeah. But I mean, it does call into question with the other study, I think, are like the exposure to radiation, the contrast risks, false positives with D-dimers. I don't know. I mean, comparing the two studies, what do you guys think?
It's hard because they're so drastically different. Right?
Yeah, that's why we wanted to bring it up.
Differences in the end, which you could have been and kind of some of it. But again, I'm not a mathematician, but it seems hard to account for that all that difference just based on the methodological challenges. Unless it's just a random effect of looking at most prevalent patients. But it's still a lot. It's not like a small end. It's smaller than a million.
I mean, I was thinking personally for patients who don't have a cause of syncope, that maybe then I would do a well score, possibly check a D-dimer. I don't know what.
I would say the second trial fits more with local experience. It's not the usual diagnosis that we find for patients maybe working for it, I guess. But
Right. So to Martine's point earlier, you were saying like that
I feel like that first study makes, yeah, this is the right thing, but the first study makes,
and plus, we since we're always on the inpatient side, we would be seeing kind of population that would be captured in the first setting. So maybe they do somehow wind up on our floor for whatever reason, then maybe that hasn't been done, and maybe we should move it out. Because I definitely have had a case or two of patients who had the episode, and the residents were like, we don't know why it happened, but she's on her service. And then I was like, she had like a train hypoxia or whatever, and then we're back.
So I think some of the limitations of this particular study were they were using all administrative data, so they were using like billing and DRG codes, which apparently have a sensitivity and specificity of more than 90%. And they didn't analyze the characteristics of people who would be more likely to be diagnosed with a PE or VTE. So like Faye was saying, like they didn't look at people with a high Wells score, active cancer, see like what populations actually had a higher prevalence. So, I mean, bottom line, I don't know what everyone thinks, but I personally think I'll probably consider it more in the differential and really just work it up if there's no room cause and there's a high Wells.
Right. So so just kind of wrap or to conclude with some of the things we've already talked about. But yeah, so what is the true prevalence of PE? And it sounds like from clinical experience, maybe we think it's on the lower end, but maybe we should be thinking that it's a bit higher, based on the first study anyway. And then as we sort of been discussing, how should we be working up with these patients with syncope, in the setting of also, over testing people and potentially giving patients a teddy for Occam's conference, when we over test them. So I know I remember when the 2016 article first came out, when they were saying 1 in 6 patients, were being diagnosed with syncope, it was definitely more on my radar, and I think even now I still try to think about, should we be doing sending a D-dimer just to make sure that it's been ruled out to just sort of give me some assurance. But I don't know what everybody else has been doing.
I mean, in terms of if we think that PE is a cause of syncope specifically, yes, it'd be on like differential, but still, I'd probably do the Wells score and see if they're intermediate probability, and if they're intermediate probability, then I'd get a D-dimer, but otherwise, I probably wouldn't change anything. For the high risk, obviously, for the low risk, don't bother. And the intermediate risk is about giving D-dimer, it's not changing. The issue is that for me, so many of our patients have recent oncology disorders, so I feel like there's so many various patients get admitted where I'm like, I get so many dimer, but it's gonna be positive, and then it's not gonna change your management, and then we're gonna end up having to.
we listed that data just for different outcomes we did for different reasons, and I reviewed only like 30 D-dimers, but 9 out of 10 were false positives. So it's helpful as a negative, you can avoid a CT scan, but I don't know if like checking a D-dimer is going to mitigate the risk of other tests for CTs. If the true prevalence is 1% and we're treating it as if it's 50%, then the third goal point is a huge problem. We're going to get a lot of false positives and a lot of unnecessary tests.
Are people using age-adjusted D-dimers for their cutoff, or they're doing it?
When I looked at it, there was only like one of those actually that had been changed.
Okay.
Changed 30 patients, but that fits with what we know.
Right. I agree with Faye though, like the D-dimers are rarely useful in a hospitalized patient, like it's gonna be positive. But it probably just delays your workup, like if you're really bad.
I mean, that's the thing. If you're really suspicious, then at least like ACP guidelines would be just a scan without getting it. But for a lower median probability, if they can't be excluded by the PER criteria, they recommend checking D-dimer. And what they found was that 10% could have avoided the CAT scan. Right. So even the flip side, yes, 9% still got the CAT scan, but 10% could have avoided the CAT.
Is that worth the extra like half a day hospital stay that it takes to like get the people to draw the D-dimer and have that?
That's a good point. If that's the test that's going to get them out of the hospital.
Yeah, I mean, usually it can be added on to stuff they've drawn in the ER, so that's.
Although it's usually the patients who we actually find negative D-dimers on, it's like your younger, healthier patients.
Right.
And also those are the patients who most don't want to radiate. Like are the young patients. So I feel like, I'm more interested in starting radiation to
I agree with you. If they perk out, that's great. But like almost no
Yeah,
one perks out, right? Our patients, yeah. If you're admitted to medicine, you probably won't perk out.
And then, I mean, if you're going to scan everyone with syncope who gets admitted to the hospital, I would definitely do D-dimer before doing that because you will eliminate 10% of the test, but I still think you're going to go to test a lot.
So,
Yeah.
the conclusion is, we don't
New
know.
England Journal of Medicine data because it doesn't fit with my clinical experience or the bulk of the data from the larger trial, although it still makes me nervous.
But also other studies, like there were other studies before it says that had incentive. So it's like I feel like the trend is more that this first article came out and everyone's like, oh my god, almost not. I mean, the second one, but no, maybe it's actually can't tell. Like
Yeah.
I think they're mostly less robust.
The other problem is I feel like the history of syncope in many of our patients coming with like syncope is like very questionable. Yeah, exactly.
Well, let's see. Well, let's look. So let's see if they had 2,600. So what's 97 divided by 2,600? Can someone do that real quick?
What was it?
97. It's 97 divided by 2,600 or 2,584.
Yeah, 3.7%.
So yeah, if you include the full data for patients, who presents the ED with syncope, and then you said what, 3%?
3.7.
Yeah, and yours was like the highest was like 2 point something percent. So that would fit more in line with our thinking, I guess. So I guess the conclusion is that it's something to be thinking of the differential, but maybe not as worrisome as we think, based on at least the 2016 trial, which was like 1 in 6 patients.
I remember a while back there was like I think I talked like Stravidia gave or something that said like 1 in 6 patients who had been admitted to they had like PE or something.
Yeah, I think this is based on this.
That was
This is
that was
based on
just
this.
okay. Gotcha.
Yeah.
This thing is like rearing its ugly head again.
The truth is somewhere in the middle, probably. Like that one series probably has way too many, but on the other hand, if you're going by the ED doctor's diagnosis, not to be disparaging about emergency medicine diagnostic ability, but there are certainly some studies looking at, for example, cellulitis, how many of them are getting the diagnosis wrong. It's an astounding percentage. A third of them. So a lot of those diagnoses are wrong.
Yeah,
So
and
that's for the ED diagnosis as the basis for determining.
Is there any reason to think that the prevalence would be different in Italy based on other factors that we're not thinking about, like behavioral, genetics, or things that, like?
They probably do smoke
They
more.
smoke way more in Italy, that's for sure.
I would be curious, like, is this regional? Because this, the second study looked at many different countries.
No, the element of Italy, but UK, it's much harder to get into the hospital. It's going to have the patients be sick. Probably not Alzheimer's, but like medications and other.
Maybe Mediterranean fever makes them hypercoagulate.
Definitely, yeah.
Well, because yours was from what, Denmark, Canada,
US.
the US, and Italy also?
So when you take a look at the second study, the way they actually calculate the prevalence is a little concerning. Because the way they actually form the study cohort is just chart review, and then they're saying that they use the ICD-9 as the 10 codes to pick up the syncope that's recorded in any diagnosis field, which means some of the data is like 25 diagnoses for each patient, and usually there's only one principal diagnosis which is relevant to index like hospital visit. The rest are usually for past medication.
Right.
So it doesn't really indicate the true.
That's true.
So they're probably pulling in past history of PE.
Exactly. So this could be, their denominator kind of overrepresenting the syncope where it's not contributed to the syncope. So I think that's what kind of have triggered the prevalence.
That's a good point. Yeah. I mean, it kind of is for any sort of retrospective chart review, you sort of be worried about that. Although I guess Mona said that there was like 90% sensitivity, specificity, whatever.
Yeah, I don't know how they determine that.
Manual review, gold standard. Well, maybe they probably did a cross section of them, right? Like just like 100,000 or so, and called it a day.
No.
Oh, they did it for 16 years. So that's, no, that is not. Anyway. All
right.
Okay, well, any other comments before we wrap up? Because it's super hot in here and everybody wants to
Yeah,
use the air conditioning. All right, well, thanks very much. Do you guys have any comments or